Ladies and gentlemen, welcome to Clinical Journal Club, March 20th, 2019, 16 o'clock, and we'll start now. The image in the New England Journal last week is, as you can see from the picture, is a gram preparation from a blood culture bottle. And the issue is an 18-year-old who presented to the emergency department with a 1-week history of sore throat, fever, and malaise. He also has pleuritic chest pain and a productive cough. We're asked what the organism is, and the choices are Staphylococcus aureus, which this gram preparation is not, Aspergillus fumigatus, which it is also not, Pseudomonas aeruginosa is a gram broad, but it doesn't form chains. Nocardia asteroides does not look like this. The fungi are usually stain gram positive because of their abundant cell walls. So we're left with the gram negative organism that forms chains. And that would be Fusobacterium necrophorum. And what this is about is a complication of pharyngitis, a lethal complication incidentally, because this patient has a right internal jugular vein thrombus, and in a moment we'll see why. This is called Lyase syndrome, and it's a frightening complication of pharyngitis. Now, gram-negative aerobic bacteria such as this one reside within the mouth and teeth, etc. If we look at the anatomy here, where the tonsils are, for instance, in this cross-section, that's very close to a fascial plane called the retropharyngeal space. It's also close to the vascular bundle. And if the pharyngitis is complicated by anaerobic infection, endotoxin, etc. items are released that could result in thrombosis of the vessels inside this vascular sheath, and the infection could spread to the mediastinum via the retropharyngeal space, and this combination of events is called Lyase syndrome. And it involves Fusobacterium necrophorum. Here's some other examples. Preparation's a little better than what was shown in the New England Journal, but what we see here are gram-negative rods that form chains. These are anaerobic bacteria that need to be treated with appropriate antibiotics. Now, the first topic in the New England Journal concerns prophylaxis against tuberculosis in AIDS patients. And the agent that was given here is rifapentine. That's a rifamycin or rifampin derivative. It's synthesized from rifampin, and basically what you can see here in the structural form, it's a macrolide antibiotic, and it's quite active against Mycobacterium tuberculosis. And what was done in this study is patients, HIV positive patients, were recruited. Some had latent tuberculosis, others did not, but because the risk for TB is so high in these patients, and because tuberculosis is now the most common cause of death in HIV patients in other parts of the world, the patients were randomized to either 9 months of isoniazid alone or only 1 month of isoniazid plus rifapentine, with the thought that a 1-month regimen might be no worse, but might be easier to obtain compliance and have fewer adverse events. So that's what was done here. HIV-infected patients who had evidence of latent tuberculosis or were living in areas with very high tuberculosis prevalence. So we can look at the patients and you can see the distribution here. Men and women are both involved, and various ethnic groups in this study that was done in Africa, Asia, South America, and also in North America. and the viral load and other aspects of the condition were such that the randomization was successful. Univariate analysis of risk factors for the primary endpoints are given here. Tuberculin skin test or interferon release assay results are given, receipt of antiretroviral therapy, etc. in the various groups. These things were also reasonably distributed. And what we see here is no difference. You can get freedom from the primary endpoint, developing tuberculosis or dying of tuberculosis or dying of some unknown cause. And that's the same in people that have a CD4 count of less than 250. Or if people had a CD4 count of greater than 250, there's no difference in these groups. And in terms of adverse events, I think we can glance at this, and the briefer treatment seemed to compare favorably with taking isoniazid for a 9-month period. And so in conclusion, this study shows that 1 month of rifapentine plus isoniazid was non-inferior to 9 months of isoniazid alone in preventing tuberculosis in this high-risk group of patients with HIV. The next topic in the New England Journal is another third world topic, and it concerns women with spontaneous abortion. And if the products of conception are not eliminated completely, or if there's some doubt, these women are routinely treated with curettage to remove these remaining products of conception. And the question is a prophylaxis with antibiotics necessary in order to improve outcomes in these patients? And so the patients that required intervention of this sort were randomized to various antibiotic regimens that were not the same in every center. Either doxycycline or oral metronidazole was given, or similar placebo tablets. So 3,412 patients were recruited from Malawi, Pakistan, Tanzania, and Uganda, and they were randomized to either prophylactic antibiotic or not. And the endpoint here is a little difficult. The presence of pelvic infection, that's what one would like to avoid, was defined by the presence of 2 or more of 4 clinical features: purulent vaginal discharge, pyrexia, fever, in other words, uterine tenderness, and leukocytosis. Those are WHO criteria that are fairly rigid but clearly defined. And before the results were unmasked, for reasons that are not entirely clear to me, the endpoint was altered to the presence of only one of these features and the clinically identified need to administer antibiotics. I'm not quite sure what's meant by that, but apparently it would be expert opinion. And I thought that we performed randomized controlled clinical trials to get away from expert opinion, but at any rate, that's what was done here. So if we look at these patients, the randomization worked okay, and a whole host of variables here were similar in both the groups. Now, if we look at these endpoints, in red here I've circled 2 clinical features according to WHO criteria. This difference is not statistically significant. It's interesting that the prophylactic antibiotic group, 1.4% developed the endpoint, whereas in the placebo group, 2.4% developed the endpoint. And with the One clinical feature, a need for antibiotics per clinician judgment, whatever that means. Again, there's no significant difference, but here we have 2.5 against 2.7. And these various other things moved as one might expect, but no significant difference was found in the groups. And in terms of adverse events, antibiotic prophylaxis, again, there are no statistically significant differences here. So the authors conclude that antibiotic prophylaxis with doxycycline and or metronidazole before miscarriage surgery did not result in a significantly lower risk of pelvic infection as defined by these pragmatic broad criteria compared to placebo. However, the authors waffle a little bit about the endpoint that they had initially selected, and an editorial on this topic is also present in the New England Journal, and the editorialist concludes that the findings suggest benefit when the original stricter criteria were used, although in terms of statistical significance, none was found. The next topic also requires some introduction, and it involves acetyl coenzyme A. And you'll remember from your biochemistry course that acetyl-CoA is a pivotal molecule in initiation of the Krebs cycle to generate ATP, but also is important in a whole variety of other biochemical reactions that are necessary to sustain life and health, etc. So the acetyl group is, these are acetyl groups, as you will remember. What's done here in this reaction is the acetyl is coupled to coenzyme A. And coenzyme A has this sulfur group at the end. Here's the coenzyme, and it's attached to ADP with this extra phosphate, high energy phosphate group sitting here at the 1 carbon position. That's called ADP, P1. And this whole complex makes up coenzyme A. And when this is acetylated, then we have acetyl-CoA. That is a background. Now, acetyl-CoA is pivotal for running the citric acid cycle to generate ATP, but acetyl-CoA is also present in a bunch of other important biochemical reactions that we'll discuss in a minute. Now, to acetylate coenzyme A, we need the enzyme ATP citrate ligase. Citrate lyase, as is shown here. So this is a ATP citrate lyase is a pivotal enzyme in the so-called citrate shuttle to generate acetyl-CoA. Now, bempedoic acid inhibits ATP citrate lyase. And we can look at the structure of this chemical compound. You'll immediately now recognize this as coenzyme A, including this ADP, P1 construct at the end. And instead of acetylating this molecule, we now introduce this other chemical structure, which makes a compound that inhibits ATP citrate lyase. And it's called in English bempedoic acid. So bempedoic acid inhibits acetyl-CoA ATP citrate lyase. Now, because acetyl coenzyme A is necessary for the synthesis of cholesterol, I'll go through that in a minute, the idea here is to use bempedoic acid to reduce LDL cholesterol. I would think this strategy might be dangerous because we need acetyl-CoA for a whole variety of other important things, including the generation of ATP. But bempedoic acid was used in a study in which patients with cardiovascular disease that ideally should have an LDL cholesterol less than 70 milligrams per deciliter. Patients were recruited that had an LDL cholesterol of about 100 into this trial, and they were given bempedoic acid or placebo. Now, this is a stage 1 study, so we're concerned here about safety issues and whether or not the principle is correct. This is not a hard endpoint study. The primary endpoint here was safety, and the principal secondary endpoint was the percentage change in LDL cholesterol at week 12 up to 52 weeks. So we'll look at the adverse events, and basically there were none, with 2 exceptions. Uric acid levels increased, and as a matter of fact, clinical gout episodes also increased with this treatment. Bempedoic acid is known to increase uric acid levels. And there were some changes in creatinine, but as a nephrologist, I'm not convinced that these are important. But there were significant differences in the bempedoic acid group, which might suggest that it could conceivably cause some problems. But if we look at the adverse events according to the intensity of background statin therapy, it looks like the complications that we might associate with statins, such as muscular related adverse events, etc., these were not increased. And if we look in terms of reduction of LDL cholesterol, the bempedoic acid group is here in blue, and LDL cholesterol decreased by about 20%. I don't think that's so impressive. Non-HDL cholesterol, total cholesterol also went down to a similar degree. Apolipoprotein B also decreased by about 10%. And I'm not sure that this is so terribly important, but CRP levels decreased from about 1.5 to 1.2 milligrams per liter, and this decrease was also statistically significant, or the authors probably wouldn't have put it in this figure. Now, if we look at a forest plot, it looks like bempedoic acid is better than placebo for a whole variety, irrespective of how old the patients are or what ethnic background they have, and whether or not they're heterozygous for familial hypercholesterolemia, etc. Audioverbindung wurde unterbrochen. Jetzt wiederhergestellt. Okay. Sorry. I hope you can understand me. I'll try to pull the microphone a little closer. The results were also favorable whether or not the patients were taking acetamib, and all these things looked like bempedoic acid is better in all these various sub-classifications according to this forest plot here. So it looks like bempedoic acid lowers LDL cholesterol even in patients that have maximum statin therapy and even if they have heterozygous familial hypercholesterolemia. Now, you'll recall that ezetimibe also lowers cholesterol by about 20%. I just put this up to remind you, ezetimibe impairs the cholesterol transporter that's encoded by the NPC1L1 gene. So ezetimibe lowers cholesterol to about the same degree as bempedoic acid in patients that are already receiving a statin. Now, if we look at this biochemistry again, here's acetyl-CoA, and the amount of available acetyl-CoA is apparently diminished if we give bempedoic acid. Acetyl-CoA is catabolized further via HMG-CoA synthase to 3-hydroxy-3-methylglutaril-CoA, and that's metabolized to methylonic acid via HMG-CoA reductase, and that's how statins work. So in essence, this treatment works along this same pathway as do basically the statins. And with the development of statins, there was also concern that they might be dangerous because they interfere with the farnesylation and prenylation of proteins, which is important, how these proteins can then be inserted into lipid membranes. But apparently statins, as you well know, are fairly well tolerated. And aside from this increase in uric acid and increased episodes of gout, the same seems to be true for bempedoic acid. Now, the next paper in the New England Journal, same topic, but basically this is a genetic study. The title says Mendelian Randomization Study of ACLY. That's the gene that encodes for ATP citrate lyase and cardiovascular disease. And basically what was done here is this is over 500,000 patients were utilized in this study. They had participated in some sort of lipid trials, many with hard endpoints. These patients, their DNA has probably all been evaluated with these 900 K chips. I didn't look at the details on this perhaps as closely as I should have. But at any rate, what was done here is variants were looked at in ATP citrate lyase, also in HMG-CoA reductase, the gene that encodes for that. Also in this cholesterol transporter that's the target of acetamida, and also PCSK9, which encodes for this adapter protein that's also involved in expression of LDL receptor. And the authors used these patients to try to assess the role of these individual genes in controlling LDL cholesterol and other lipid variables. Now, I can't go through all these genes separately, but I did go through the one that's the major topic of today, ATP citrate lyase. And what they did is 1, 2, 3, 4, 5, 6, 7, 8, 9 SNPs in ATP citrate lyase were evaluated here. And if you look at the individual SNPs, the effect of each individual SNP on LDL cholesterol is trivial, with perhaps 2 exceptions. Here's a 5 milligram per deciliter effect, and here's a 4 milligram per deciliter effect. But these effects are relatively small. And the SNPs in these other genes, also the individual effects and how they come about isn't known, but the individual effects are relatively small. This is an association study based on phenotypes, cardiovascular disease, elevated LDL levels, to see what SNPs in these individual genes would fall out, as opposed to the usual GWAS study where we might have one phenotype and then all the SNPs in the body are evaluated. So this is a PheWAS instead of a GWAS, if you prefer that kind of jargon. And what we see here is the effects on gene variants and ATP citrate lyase are similar to the effects that are seen in HMG-CoA reductase in terms of the entire variables, lipid variables that are located here on the left hand of your slide. I suppose that's not too surprising, since ATP citrate lyase lies in the same pathway as HMG-CoA reductase, but the magnitude of these effects seems similar. So it might be possible that were the order of drugs here and the other way around, that we might have seen a more dramatic reduction in LDL cholesterol with bempedoic acid and then adding HMG-CoA reductase inhibitors on top. But that wasn't tested. But at least on the basis of the genetics here, association genetics, the target of ACLY seems to have the same significance as HMG-CoA reductase. And we can look at they developed a score on the basis of these SNPs, and these effects are seen in patients with whether or not they had major cardiovascular event or myocardial infarction or coronary revascularization, etc. And actually, the genetic scores from these other genes that were tested were basically similar to ACLY or to HMG-CoA reductase. Here are some additional stratifications shown here, comparing these individual genetic effects. And if we add these things together, we should have an increased effect, as the drug study that we just looked at with bempedoic acid seems to imply. And then the issue that came up, in the 500,000 people here, some of them got cancer. And the question shown in this table is, does cancer show up with any of these variants in any of these genes? And that does not appear to be the case. So these variants in ATP citrate lyase and HMG-CoA reductase were associated with similar patterns of change in lipid compositions. This is basically a PheWAS study instead of a GWAS study, and it was largely supported by the company that is producing this new product. So there's also an editorial in the New England Journal on Human Genetics and Drug Development that go over some of the thinking that I've just shown you in this study, and you can have a look at this graphic. Basically HMG-CoA reductase and ATP citrate lyase and even PCSK9 all have an influence on the expression of the LDL receptor, so they're in a similar pathway. So perhaps these findings are not so unexpected. The author of this editorial does mention the propensity towards the development of gout, and also that the numbers of patients that were hospitalized for heart failure seem to be increased. These changes are not statistically significant, but at any rate, they're not encouraging, at least not to me. So we're going to see additional studies, I'm sure, on bempedoic acid, and then we'll have to make decisions. I'm sure that hard endpoint trials have to be done, which were not positive for N-acetyl-CoA to my knowledge, but we'll see how that falls out. The next topic in the New England Journal is also a continual problem, and it has to do with opioid prescriptions in the United States. Now, the CDC has issued guidelines of opioid prescriptions, and the idea is hopefully that since 2012 to the present date, that the prescriptions somehow decrease in number. Now, all of this is predicated on a development in the 1990s in the United States where somebody developed a scale that I've called the dolorimeter. And the dolorimeter is a subjective assessment by the patients of how much they're hurting. This is not an objective assessment in terms of looking at substrate for pain, but you can look at it here, even if it's in German, no pain or worst conceivable pain. And then the subjects are supposed to pick the smiley face that most fits with how they feel. This sacred cow has not been touched in the United States to my knowledge, and perhaps that's where they should be directing their attention. Because if we look at the prevalence of opioid prescription and the incidence between 2012 to 2018, there is a decrease. And even the incidence has decreased. But in my view, it's not dramatic. And if we look at it in terms of 100% of enrollees in Medicare and Medicaid, if we look at the raw data as they are, I don't think that I would notice this. I guess there is a decrease here. And if we blow this up, we can see that. And if we look at this in more detail, more than a 3-day supply, I've interpreted that as probably a week or more than 1 week's supply. There has been a decrease in the amount of prescriptions in terms of also in the morphine equivalent dose. Now, green here is a 50 milligram per day morphine equivalent dose, which I think is a lot. And here there are even 90 milligrams of morphine equivalent per day. These things have gone down. Here's in actuality what really happened, but they have gone down. Everybody's very happy about that. If we look at the patterns of these prescriptions, there's a seasonal change here, which I think has to do with, the authors discuss this, seasonal changes in case mix, more accidents, motor vehicle crashes might be more common in good weather compared to bad weather. I think it also has to do with, in German, what we call Quartalsabrechnungen, where these physicians have to look how much more money is left in their budget, whether or not they can afford to prescribe this stuff. But there is a sort of an interesting up and down pattern that's seen here. So the providers there's not much evidence that the providers were very much influenced by these guidelines that were issued by the CDC. I don't think that there's a magnificent drop here, but that's a matter of discussion. So this is the problem. And the findings illuminate some aspects of opioid policy in the United States, but perhaps the policies should be directed at the subjective feeling of this pain scale. We didn't have this problem before the dolorimeter was developed. The review in the New England Journal has to do with space medicine. And the concern here is that thus far, all the people that have been shot out into space are very well fit. Most of them are well trained as aircraft jet pilots and various things. But now with civilian space flight and making this commercially available to any idiot that wants to be shot up into space, general physicians need to know about the problems that these patients have. So you can have a look at this review, because we have to decide what kind of flight is it. And if it's a suborbital flight that lasts only several hours, then the risks are longer or are different than if the patient is involved in a trip to Mars. And we can look at long-term effects being minimal or greater. If the sojourn is more than 48 hours, then we have to think of radiation damage, spaceflight associated neuroocular syndrome, and we'll go into what that means, or both, and changes that occur in the cardiovascular and musculoskeletal system in longer spaceflight. So we have to consider G forces, taking off, landing, and in which direction the acceleration vectors occur. And the participants are in such a position when the rockets go up that their G forces are across the chest rather than being from top to bottom or from right to left. And in that way, they're more tolerable, but there's still effects. Now, what happens to these people when they're up in space? A whole variety of things happen. And perhaps the most important is this spaceflight associated neuroocular syndrome, where the patients may get papilledema, cotton wool spots, which are infarcts in the neuroretinal layer occur. The patients get more nearsighted because the size of the orbit decreases, and this may get better once they're back down. Bone density effects are important, and there's enough loss of skeletal calcium so that kidney stones can develop. Radiation-induced changes are less defined. Muscular deconditioning is a major problem because when these poor people come down after having been up there for months, they have difficulty standing up for a variety of reasons. The vertebral axis actually increases in length because the intervertebral discs swell, which can result in back pain. That all of this space travel could be frightening, I can imagine that. Then there are neurovestibular changes, motion sickness, and changes in fluid shifts that result in nasal congestion, headache, and other problems. And there are areas of uncertainty. So this will be interesting to observe. So if you're a physician to a patient that's planning to a longer sojourn in space or to the moon or to Mars, if you've read this review, you'll be able to advise them accordingly. Then here's an image in the New England Journal. It's an HIV positive patient from French Guiana. And here's his peripheral smear. This is stained with Giemsa. These are myeloid cells. And this one has these peculiar inclusions here, which an expert might recognize as histoplasma capsulatum, which was, so this patient has histoplasmosis, a condition that we encountered very commonly in the United States Midwest in Indiana. But this patient acquired his histoplasma capsulatum in French Guiana. Then here's the patient from last week, this patient with the St. Mary Joseph's nodule. You'll recall that St. Mary Joseph was a Catholic nun that worked for the surgeon William Mayo at the Mayo Clinic, end of the 19th century, and she actually drew William Mayo's attention to this umbilical nodule, which is a metastasis in this patient from an ovarian cancer that you can see on this CT. And this is a classic lesion implying the presence of an intra-abdominal malignant process. Then the case of the week also concerned me considerably. It's about a 58-year-old woman that has vision loss, headaches, and oral ulcers. So she develops all these aphthous lesions in her mouth. She also develops conjunctival ulcerations and basically episcleritis. Somebody asked her dolorimeter, and she's an 8 on the scale of 0 to 10 in terms of pain. We see a whole bunch of laboratory values that were obtained by these physicians, and basically they aren't helpful. She also had tests for anti-nuclear antibodies, rheumatoid factor, ANCA, which I think was a good choice, and these various antibodies were all negative and nobody knew what she had. So the observation was made that she's HLA-B51 positive. HLA-B51 occurs more commonly in patients with Behçet's disease if they're from the Mediterranean area. Whether or not that applies to North Americans is considerably less certain. But basically the diagnosis of Behçet's disease was made. So the patient received rituximab, cyclophosphamide, cyclosporin, and a whole bunch of other things that didn't make her better. This is a fundus photo, and we can basically see that the optic nerve head here, I can just sort of basically make it out. The experts tell me that vitreitis and retinitis are present in this photo. So here we have this patient with a severe eye disease, visual loss, ulcers in her mouth, but not genital ulcers, and the other usual candidates that were looked at in terms of autoimmune diseases were negative, but the diagnosis of Behçet's disease was nonetheless made. Then we look at her palms and other aspects of her body, and she has a rash that involves the palmar surfaces. And somebody looks at her eyes a little more carefully, and the right pupil was non-reactive to light. Some of you might remember Argyll Robertson and the pupillary signs that he described in the 19th century. That might be a good clue. This problem would have never happened to my generation, where at the time, I graduated in 1968, serological tests for syphilis were done on every patient that came into the hospital, whether they liked it or not. We didn't tell them about it unless they were positive. But I was taught by my teachers that any patient that has a rash on the palmar surfaces of both hands has syphilis until proven otherwise. And then cyclophosphamide and rituximab wouldn't help. Well, the story goes on. She's an 8 on her dolorimeter scale, so she gets hydromorphone, gabapentin, ketorolac. Don't even know what ketorolac is exactly, but etc. Then someone decides that she might have herpes virus, so foscarnet and ganciclovir are given, and then more intravenous methylprednisolone and oral prednisone and tacrolimus creams and all sorts of stuff. So then this is discussed by an expert, and the expert throws doubt on the diagnosis of Behçet's disease. The HLA typing is not helpful in North Americans, so the fact that she was B51 positive is not relevant. The fact that she doesn't have any genital ulcers is fairly strong evidence that she doesn't have morbus Behçet. Scleritis can occur with syphilis, and uveitis can also. And this palmar rash and eye disease are seen in syphilis, psoriasis, reactive arthritis, Kawasaki's disease, and Rocky Mountain spotted fever. I don't think she had the last two, and there's no evidence of psoriasis, and reactive arthritis, less certain, but this would be my candidate. And then the possibility of syphilis is discussed here, and the patient was HIV negative, but that's also a consideration. So eventually a skin biopsy is made, and here is Treponema pallidum as shown in this biopsy. So this woman had syphilis, and she was treated with penicillin, which worked a lot better than rituximab or cyclophosphamide. A little commentary in the New England Journal on soluble FLT. Soluble FEMS-like tyrosine kinase 1, or soluble FLT, is a soluble form of the VEGF receptor, which also binds to placental growth factor. And soluble FLT is implicated in the development of preeclampsia. And there have been attempts to remove soluble FLT with plasmapheresis kinds of studies, and these studies are suggestive concerning soluble FLT and the pathogenesis of preeclampsia. But it occurred to some investigators that maybe we could just shut off soluble FLT with siRNA. And that strategy has been tried. And the paper on which this commentary is based was present in Nature Biotechnology. It involves a preeclampsia model in primates. It's a ureteroplacental ischemia induction model. And as we can see here, these are the monkeys that are in blue, and their soluble FLT levels indeed go up. Their systolic blood pressure goes up, and they get proteinuria. And if we treat them with an siRNA against soluble FLT so that soluble FLT isn't synthesized, then these items are ameliorated. So maybe this will develop into a treatment for preeclampsia. Then there's a question in the New England Journal, question of the week. It concerns a woman who's had repair of a tear of her anterior cruciate ligament. And the question concerns how should she subsequently be treated. The first item is neuromuscular training. Now, I'm aware of muscular training, but I'm not aware that nerves can be trained. Maybe I'm wrong. Second choice, isolated hamstring strengthening. Sounds reasonable. Avoidance of nonsteroidal inflammatory drug therapy. I always think that's a good idea. Or early immobilization. I'm not so keen on that. Therapeutic ultrasound and electrostimulation. Sounds like some sort of magic. So we're stuck with neuromuscular training, and that indeed is the correct answer. And I learned that neuromuscular training is an intense physical and mental, I guess that's where the neuro part comes in, conditioning process. So you can look at that. Then in the Lancet, the first two papers involve adolescents worldwide, or at least lots of adolescents. And it might occur to you that since 1990, we have a lot more adolescents on the planet than we have many more adolescents on the planet in 2016 compared to 1990. As a matter of fact, there have been 250 million more adolescents introduced to the world population, and most of them live in multi-burden countries. I think multi-burden is UK English for poor. Now 1.8 billion people on the planet, there are 7.5 billion as far as I know, are adolescents. That means that they're basically children under the age of 18. So we need to find out what the level of their health care is. And it's not ideal. And they have their problems with DALYs and QALYs. In terms of injury, tobacco use, binge drinking, increase in obesity in adolescents is massive, anemia, and NEET, which means not in education, employment, or training, child marriage, these kinds of things. I think this graphic here is quite interesting. Everything in green here is non-communicable disease predominant. Basically, this means obesity associated probably with an increase in blood pressure, increasing the risk for cardiovascular disease. So in 1990, the green areas, Germany, Scandinavia, Australia, Chile, and I'm surprised to find Paraguay on this slide, was relatively modest. But now in 2016, much more of the world has turned into non-communicable disease predominant. And injury excess, areas shown here, multi-burden, everything's wrong, mostly infectious disease, still sub-equatorial Africa and India, etc. So you can look at the details in this report and how things are developing in terms of health outcomes. The girls are in blue here and the males are in red. I would probably put this the other way around, but the DALYs, daily loss in quality life years, seems to be increasing for these adolescents. Their health risks are certainly increasing, and the social determinants of health, you'll remember that variable in terms of education, income, and what's done with these young people is also leaves ground for some pessimism. So that's this report. Then the next report concerns, again, adolescents. 5-year-olds aren't adolescents, but basically this is about children even younger than in the last report. In India, China, Brazil, and Mexico. Are these multi-burden countries? Well, they shouldn't be. India can afford an atomic bomb program. Maybe they should pay more attention to their young children. And China, 2 out of 4 are atomic powers, and Mexico and Brazil also have lots of resources. It looks like communicable disease still account for nearly half of childhood deaths in India, and that doesn't inspire confidence. So we can look at details from this report. Annual reduction seems to be relatively modest, but some things have gotten better. For instance, deaths related to diarrhea have decreased in India substantially from 2005 to 2016. Pneumonia is down, malaria and tuberculosis are down, meningoencephalitis, and if the kids get vaccinated, they do better. China's done remarkably well compared to India, at least if we look at deaths related to diarrhea, and their vaccination program seems to be superb, and the deaths from malaria and meningoencephalitis are also relatively modest. And here we can compare boys to girls, and cancer is actually, and neurological diseases remain fairly flat in these countries, but drownings, we should probably be teaching the kids how to swim. The Chinese have made some progress here. In other countries, this progress has been less apparent. Homicides, Brazil, access to firearms, Mexico, access to firearms compared to these other countries. Suicides, these are all preventable deaths, as you know. Now, the next topic in the Lancet is Kawasaki Syndrome. And this is a mucocutaneous lymph node syndrome that basically results in a middle vessel vasculitis that typically affects the coronary arteries, so that aneurysms develop after several years after the acute event. And this is just a chest x-ray in a young person who has these huge coronary artery aneurysms that are calcified that you can see in this plain chest film. And these youngsters develop fever, arthritis. They may develop myocarditis acutely and then later aneurysm formation. They may have skin changes, adenopathy, etc. This is a difficult clinical diagnosis. And the treatment that's applied is the administration of immunoglobulins. Now, Japanese investigators, through some genetic inferences, found some evidence that perhaps NFAT activation is involved here, And so they reasoned that perhaps cyclosporin, in addition to immunoglobulins, would help these children and avoid the development of aneurysms. So they randomized children to intravenous immune globulins plus cyclosporin or intravenous immune globulins alone. And they measured a whole variety of variables here, also in terms of coronary arteries. And perhaps it's too soon to find a difference here, but if we look at this maximum Z-score that's shown here, it looks like the IV immunoglobulin plus cyclosporin group does a little better than the immunoglobulin alone group, although these measurements of these coronary arteries, but it's only 80 days after initiation of treatment, perhaps we wouldn't expect to see a difference by then, is less impressive. But what is impressive is the development of fever going away was better in the cyclosporin group, and CRP levels, signs of inflammation, improved also faster in the cyclosporin group. And the numbers of relapse cases and the numbers of cases that were designated as non-responsive to therapy was better in the group that got cyclosporin in addition to their immune globulins. So you can look at details here. Adverse events were limited, and so it looks like for Kawasaki Syndrome, giving the kids immune globulins plus cyclosporin, at least for the duration of this evidence that we have from this study, seems a reasonable thing to do. The next paper in the Lancet involves type 2 diabetes and patients whose pancreas has been damaged to the point where insulin replacement therapy is necessary. And this is a problem because the control of patients with type 2 diabetes that receive insulin is poor. And the total dose of insulin that these patients get is variable through time, as shown by this simple example. But these patients, here is getting 120 units a day, which I think is quite a bit. But these patients that no longer make insulin and nevertheless are insulin resistant, we might imagine they need more insulin. But perhaps there's a better way to take care of these patients. And there is a strategy called the DNAV device. And the patients here have to take a blood sample at periodic intervals, several times a day, and the device tells them how much insulin they should give. And an example of how this is applied and the insulin dosage that's given at various time intervals is shown on this slide according to this device. So the patient sticks himself, and the device tells him how many units of insulin are necessary to cure the problem. And so the providers of this device think that this is a better way to manage insulin in patients with type 2 diabetes. So here's an example of a randomized controlled trial. And it was performed in various cities in the United States, and the criteria on what basis these patients were insulin dependent is shown here. And at any rate, they managed to find 236 patients who were screened for eligibility, and they were randomized to treatment and then followed with endpoints of glycemic control, administration of other drugs, etc. At least the randomization worked successfly. And the other drugs that these patients got, some of them are getting SGLT2 inhibitors, but not very many. GLP agonists, also a minimum number. And most of them are also getting biguanide, sulfonylurea. Some are getting sulfonylureas. And what we see here is a change in HbA1c. And HbA1c decreased more in the intervention group that used this device compared to the control group. And details reduction in HbA1c are shown here, and it looks like significant differences are listed here, so that it looks like the device results in better glycemic control in these patients with type 2 diabetes. But I draw attention to the fact that the patients with type 2 diabetes using the device required a substantial increase in their daily insulin dose, and they gained a corresponding amount of weight because the administration of insulin in patients with type 2 diabetes is associated with weight gain. Nevertheless, hope springs eternal, and perhaps this device might help some patients with this DNAV insulin guidance system might help some patients with type 2 diabetes. Then from JMA, is catheter ablation better than giving pills to patients with a new onset atrial fibrillation in terms of their quality of life? And the issue here is some patients with a new onset atrial fibrillation revert spontaneously when they're given medication. And some patients that are treated with ablation relapse, and who does better. So these patients were monitored for a year, and their atrial fibrillation burden fell from 25% to 5% in the ablation group, but it fell from 23% to 11.5% in the medication group. But nevertheless, on the basis of various scales judging quality of life, it looks like the ablation group did better. So here's some details on these subjects that were randomized in this study. And this is baseline. And the blue group is the ablation group, and the yellow group is the medicines only group. And we can see that at the baseline values, these figures are all basically similar, with one exception, the role of emotion. Don't know exactly what that means. But if we look finally at the end of the study, the blue group seems to do a little better than the yellow group, although I don't think the differences are knock your socks off. But if we look at atrial fibrillation burden, symptomatic atrial fibrillation, that is better in the ablation group compared to the medicines alone group, although there's a lot of variability here. And lastly, in the same JMA issue, is what the current guidelines are in terms of atrial fibrillation, patients with new onset atrial fibrillation, who needs to be anticoagulated. That's important. There's a new CHAD score that I'll show you in a minute. A value of greater than 2 in men or greater than 3 in women should be anticoagulated. The trend is away from warfarin to novel oral anticoagulants, which are probably more convenient for the patients, and who is to be cardioverted, what to deal with patients that are eligible for cardioversion, which patients should have their left atrial appendage closed. That's all shown in this brief guideline here. And the new CHAD score, heart failure, hypertension, age, diabetes, if you've had a stroke already, vascular disease, and male or female are listed here. And so you can decide whether or not your patient is a 3 or greater or a 2 or greater and treat them accordingly. Then at the end, here's a finding seen on gastroscopy in a patient that was actually being gastroscoped for Barrett's esophagitis. And she has this very black lesion here in her stomach, and it's biopsied. And she also has some other lesions that are seen here in her liver. And then someone takes a history, and 13 years earlier, she had removal of a uveal melanoma. And this is a late onset metastasis from uveal melanomas that have individual problems, including mutations in certain genes. And so uveal melanoma, brief discussion, tend to recur, genetically based, and that's it for this week. So join me again next week if you can tolerate it, or if you like, we can hear the same business in German in 1 minute. Thank you for your attention.